Hello people, this is Dr. Muskaan this side, and today I am going to discuss one very beautiful case. Here is 20-year-old male who works in factory, studied till 10th class, resident of Kasna, came to OPD with the chief complaint of abnormal body movements. There were 4 episodes in last 25 days. So HOPI, the patient presented with complaint of abnormal body movement which was stiffening and twitching type. There were 4 episodes. One was on 3rd October at morning 8 am. Second episode was 4 hours later. He took the treatment from nearby doctor and there were 15 symptom free days. And another episode was on 16th day in the evening, and fourth episode was on the 17th day in the early morning 5 am, which was associated with confusion, altered sensorium. There was family stress, there was white frothing from the mouth, there was feeling of lightheadedness and followed by faint. There is negative history of tongue bite, palpitations, sweating, fever or cyanosis. And also there was rapid recovery in 3 to 4 minutes after having this abnormal body movements. Past history: there are no comorbidities like type 2 diabetes mellitus, hypertension, epilepsy, TB contact, thyroid or any other comorbidities. Past surgical history: there is alleged history of head trauma. When he was 6 years old, there was blood loss, and there was positive history of blood transfusion. There are sutures on the forehead, and brain trauma was present. Personal history: patient is non-vegetarian by diet, and this is very important in our case because he eats uncooked meat in some days. There is bowel and bladder habits are normal. He takes beer occasionally, and he takes occasionally cigarette and smoke also. The sleep habits are normal. Now, investigation picture of the patient: CBC shows anemia and leukocytosis. Urine routine microscopy was normal. Lipid profile was normal. HbS antigen HIV 1 and 2 HCV was non-reactive. Thyroid profile was normal. Now, NCCT brain, that is non-contrast CT scan of brain, was showing infective granuloma which is suggestive of neurocysticercosis. MRI brain shows multiple tuberculomas. After finding neurocystic cirrhosis which came in the CT scan, further multiple tuberculoma was present in MRI, and we are making the diagnosis using diagnostic criteria of neurocysticercosis. And to make the definitive diagnosis of neurocysticercosis, there is one absolute criteria, there should be one minor criteria, and there should be one epidemiologic criteria. The absolute criteria present in this patient was cystic lesion with scolex on neuroimaging. The minor criteria was lesion highly suggestive of neurocysticercosis on neuroimaging, and epidemiological criteria is household contacts with tinea. Hence, it fits in diagnostic criteria suggestive of neurocysticercosis. Management of this patient was they were managing the seizure activity. There was supportive care of ABC. They were monitoring and correcting the metabolic abnormalities. Anticonvulsants were given. The drugs such as albendazole, praziquantel, and steroids such as dexamethasone and prednisolone was given. Ocular management was done. That means there was some surgeries. Spinal management: there was some intramedullary cyst which was treated by surgery. And the prognosis in this case: if there is a single lesion, there is a good prognosis, but if there is a multiple lesion, there is more frequent seizures which can be present. So prognosis is poor in cysticercal encephalitis and extraparenchymal neurocysticercosis. What is neurocysticercosis, my dear friends? Let me tell you a little more in detail in this history. There is infection of tapeworm or tinea solium. The cyst is present in brain. There is one definitive host, there is one intermediate host. Definitive host is human, intermediate host is pig. And we also do one test, that is CSF analysis, in which we get that protein might be normal or increased, glucose might be normal or decreased, and lymphocytes are present. Now, when I was taking the history of this patient, I also ruled out that it might not be syncope apart from seizure. They both resembles altogether. In seizure, cyanosis is present, tongue bite is present, confusion is present, amnesia is present. Rapid recovery and stress are absent. But in syncope, cyanosis, tongue bite, confusion, amnesia are absent, and rapid recovery and stress is present. So I really enjoyed learning on this case. I hope you also get some good points listening to the history of the patient. Hence, Dr. Muskaan signing off now.